Welcome to SAPH 2023. This is our 16th annual meeting for pulmonary hypertension.
Real pleasure to be here after many years, and it's always a real pleasure. Thank you.
Now, the question, therefore, is do the ECHO guidelines, which have only changed marginally from 2015 to 2022.
طبعا فالدكاترة بيشوفون مرضى ضغط الشريان الرئوي بأنواع المختلفة.
وكانت في البدايات يعني ما في تحديد لأنه أنتي فاسفولبيد كانوا معتبرينه تخثر دم عادي، واستمريت على الورفارين.
Enzymes regulating night, for instance, BMPR2 loss of function,
mediators, genetic drivers, mediators like growth factors.
You have a chance of individualized therapy. Measure their risk based on implantable monitors.
Stimulates endothelial angiogenesis and the formations with KLF6 overexpression compared with the control.
Study will study in heart failure patients to HX, but when you put them into your organ on a ship and you start exposing them, we use the KLF6 and that it has zinc.
Have a role in the future in that it's in an expert center doing.
And what do you think the inhaled imatinib will
about the new updated guidelines, from the definition to the risk stratification to the impact on the treatment.
It was used in different ways by different centers and by taken feasible treatment goal for these patients. And the question is that relevant for the patients with
400 patients who started that study being on the ERA PDE5 inhibitor combination background?
By an increase in pressure and precapillary by an increase in resistance.
In everybody, and that you have patients who are even functional class 2 doing fairly well, and you have patients who are.
We know that the zero data for this patient in terms of
is really important, and I see that it really does.
Failure, me being a cardiologist and a heart failure specialist.
The initial cause, and it's insisting on the very unique population of elderly males.
6-minute walk test that you're looking at marked or worsening lesions, but vasculopathy is there.
Basically phenotypes. So again, Maris Hooper from the data from both Compera and the Aspire looking at
utilize according to different treatment strategies.
But these are the metrics that you have, potentially changing the recommendation level.
In Victoria was very peculiar in the way that that's the overarching mechanism. Then some patients derail, and
so the chances of them developing post-capillary is it?
I mean, in the way that we're talking about a disease that it has a lot of high PV.
When Compare data was published, and one of the things that was notable get you that far, I think in the future, looking at parenchyma.
Going to be very exciting live cases.
Difficult decision to make a decision to send the patient for right heart cath. So
P was 813. His 6-minute walk test, he had a saturation of 94%.
The disease associated to PAH can be also improved in addition to the vasodilatation.
Underlying CTD in PAH. Thank you for showing this case.
This may induce quite rapid.
Class 4 upon her presentation. Her symptoms was associated with orthopnea.
Also, if you go look for another article and people who have people.
One of the key approaches if for such patient you try to optimize their situation.
Diagnosis, then the second part inshallah will be a follow-up for the case. Her CT showed bilateral non-specific ground glass opacity and no feature.
All the organizers for the fascinating meeting as usual, and the very nice program and the entertainment. Everything actually is
basically utilizing a large healthcare data
insurance, clinics, hospital episodes, emergency visits.
Or if you wish, the coupling between the ventricle and the pulmonary circulation times, because we are here putting the goal of saving the patient life as a priority.
We allow pulmonary hypertension in the adult population, but pulmonary hypertension early in children of parents who have
patients in the ICU, specially seated patients, to extent we can.
Pulmonary hypertension in children, because it needs long time to develop this.
Oxides, and whether the use of targeted therapy. That
a proper workup to really establish pulmonary vasodilator therapy.
Automatic patient. Is there any data that came negative with detect applied?
To help guide you whether to send them to the right heart cath or no. So I think that's my answer.
They convert them to two ventricle surgery, and they think their subaortic LV is not carrying the circulation.
Usually norepinephrine plus vasopressin is the common practice that we do in our ICU.
PEA had showed in highly study, because that study did not do pre and post.
Highly inflammatory markers. They found actually athrombotic lesions.
It's a very good topic. It has evolved extremely well over the years, and there's a lot of turbulence, stop flow. Again, in
very important question. Yes, we know, as we see in daily practice,
better MDT and a much clearer separation.
Who have BPA who are older, could you come in with?
Do you advise to repeat the PEA, or you will go just directly for BPA or medical treatment?
Disease, the more difficult technically when you do BPA. The more proximal disease you have, the more easier that.
Best journey back home, and we'll see you in SAPH 2024. Thank you so much.